Thanks for joining our XGeneIQ short patient scenario regarding optimizing cardiology medications using pharmacogenomics. Cardiology is an extensive area with multiple curated guidelines and annotations for various medications, such as Plavix, Warfarin, and Statin when PGx results are available. Let's introduce the patient scenario to focus on optimizing three major classes of medications in the field of cardiology using pharmacogenomics. Our patient is a 76-year-old male who's scheduled to go to cath lab for PCI. The provider would like to know if Plavix is the right choice for this patient. For that reason, a preemptive pharmacogenomic testing is going to be done. Additionally, the patient has been complaining about muscle pain, and the provider would like to know if statin is a cause of this muscle pain. And this is another question that could be answered by the pharmacogenomic test result that are listed down here. As you can see, the patient is a poor metabolizer for cytochrome P450 2C19, which is responsible for metabolism of Plavix. Plavix is a prodrug and requires this metabolic pathway to get activated. So if this patient is a poor metabolizer, this activation is not effectively happening. And as per CPIC guidelines for patients with a poor metabolizing genotype, the recommendation is to use an alternative antiplatelet agent such as prasugrel. So the answer to this question is that we realize that Plavix is not a good agent or a good medication for this patient to use post-PCI. As far as the simvastatin goes, simvastatin goes through this metabolic pathway for which the patient has lower functionality. This is the metabolic pathway here. And as per CPIC guidelines, this puts the patient at higher risk for myopathy. And since the patient is already complaining about the muscle pain, then our recommendation when we wrote our medication action plan to the provider was to change this simvastatin to pravastatin, which is a non-cytochrome P450 statin. Additionally, changing to pravastatin mitigates the interaction that simvastatin has with amlodipine. As per FDA recommendation, when these two are used together, the dose should not exceed more than 20 milligram. Currently, the dose is at 20 milligram, but to completely mitigate this drug-drug interaction, going to pravastatin, which is a non-cytochrome P450 statin, will totally eliminate this interaction. Now, how do we go about optimizing warfarin? The patient is going to be needing mechanical mitral valve replacement and ongoing warfarin therapy for that reason. PGx results can give us guidelines on how to initially dose warfarin. As you see here, this is the genotype of the patient. And if we put it in this package insert and connecting the CYP2C9 genotype with this genotype of this gene, then we can see that the initial dosing for the patient, appropriate dosing, would be about 3 to 4 milligram. Now, if the patient had any of these allele variations, then we would have recommended higher or lower dosing. But this patient did not have any of these allele variations. We hope this patient case was useful to you. At RxGeneIQ, we value our collaboration with providers and their referrals. If interested, please feel free to view other patient scenarios or sign up to be on our mail list for future patients' cases.